Welcome, everyone, to today's episode of Arthritis at Home. I'm Kelly Lendvoy, your host, and today we're speaking to Cheryl Koehn, ACE's president and founder, about the release of the 2025 rankings in the Arthritis Consumer Experts Arthritis Medications Report Card. Cheryl, welcome.
Thank you. Hi, everyone.
ACE's report card is one of the Canadian arthritis community's most valuable advocacy resources and is a specific tool that ACE has helped patient organizations from other therapeutic areas develop for their audiences. Cheryl, I thought to start, for people who haven't seen it before, you can tell us what the report card is and how did it originate?
Well, I'll start with the second part of the question first, and that is it was created and launched in 2007, 7 or 8, and the first sort of sighting of it was actually on Parliament Hill. We
Hmm.
held an event there to draw attention, Kelly, to the inequity of reimbursement access to, yes, high priced, but also high value therapeutically medicines in the arthritis medicine chest, namely at the time, biologic response modifiers. And as that medicine chest grew, so did the inequities in terms of access to them on public formularies. So ACE decided to roll up its sleeves, look at province by province and what the specific criterion were to actually qualify for reimbursement. And of course, we found it was all over the map. So that's one way to create inequity is interprovincially. And then second, there were some provinces, Kelly, that required people to fail on multiple medications, ones that weren't even being used anymore to treat inflammatory forms of arthritis, which is generally what biologic response modifiers treat. And so we had all of these things we were trying to tackle all at once on the report card. And we thought, what better way of calling someone's, namely government's, attention to it than by ranking them, actually ranking them in a report card style. Think about when you were an elementary school kid and you knew you had to take your report card home to your parents. You didn't want to suffer the wrath of a bad grade. So you worked hard in school all year to get a better grade. And that's exactly what the report card was intended to do. It was friendly competition between provinces. It was meant to sort of spur that on. It was an absolute shining of a light on the performance of drug plans, public drug plans, which are supposed to be providing equitable care across the country and weren't. And so that was the origin of it, Kelly. It was literally shining a light on the performance of public drug plans and showing provinces across the board, coast to coast to coast, who were the laggards, who were not serving their citizenry well. And it actually worked, Kelly. We saw provinces really paying attention to the report card and wanting to do better.
So let's take a closer look at the actual measuring uh, tool aspect of it and what we're trying to capture here. It's a big undertaking in terms of the work behind the scenes because ACE is constantly monitoring all of the public drug plans across Canada for any changes they're making to their listings in their formularies or pharmacare programs. And what we also do each year is release an annual version that compares, in this case, performance over 12 months from October 2024 to today, October 2025. What are we actually monitoring for, and what are we actually measuring and ranking, Cheryl.
Right. So at the end of this video, I know you're going to provide a link to the report card and
Yep.
folks can go and take a look at it. So I'm going to just describe briefly what they'll see. So just imagine it as a grid, a matrix, and you have most of the primary forms of disease across the top, and you've got the provinces down the left-hand side. And you have all the medications that are used to treat those diseases sorted by province. And so we're talking about things like rheumatoid arthritis, Kelly, ankylosing spondylitis or spondyloarthritis, psoriatic arthritis, lupus, juvenile, and on, right? So the primary forms and the forms of arthritis that these, what we call in our world, advanced therapies. So biologics, either originators or biosimilars, as well as targeted small molecules. These are known as advanced therapies. So we track by disease, we track by province, and we track by medicine per disease. And people can go, Kelly, and hover over each of those little boxes and click on them, and it will bloom a small little descriptor which tells them, is it covered? Is it not? Is it under review? Has it been declined? And based on that, it's kind of like a New York Times puzzle, actually. Based on that, whatever you find there, if it's declined, the province gets penalized, right? There's a ranking system, so there's a point system. So someone who has a disease like me, rheumatoid arthritis, if I live in Saskatchewan, I can go to the report card, find Saskatchewan, look at the list of medications, and if my rheumatologist and I are trying to decide what to go on, then I can actually go and look and see exactly what criterion I need to meet to receive public drug plan reimbursement for that particular medication. So, and it's, as you said, updated every month online. And then once a year, we do this huge roundup and we report out not just to people who are our members and the public with arthritis, but to government as well. We like keeping them. And frankly, this report card is on everyone's desktop. They all know about it if they're working for a public drug plan, because they really do care how they are ranking next to, their fellow neighboring province.
So, particularly important, it seems to me, for someone who's, let's say, newly diagnosed or changing treatments. That's a time that can be incredibly confusing and stressful. And we're bringing all that information together in one place for them to be able to look at. And when they're talking with their rheumatologist, have an informed discussion. And I guess the other thing that, you talk about, that patient living in Saskatchewan, they can find out which medications are publicly reimbursed in Saskatchewan, but they can also see how that compares to Alberta or Manitoba
Absolutely.
and other provinces. And that obviously kind of feeds into that advocacy component that you're talking about. And that is, why should it be different for a person living in Saskatchewan than it is for a person living in another province?
For sure. It brings the obvious question right to the tip of your tongue. And hopefully, people push that down to the tip of their fingertips and they write to their elected official and say, hello, rheumatoid arthritis or, spondyloarthritis isn't different in Alberta than it is here in Saskatchewan or in British Columbia. Why does an Albertan have coverage for that and I do not? What's different about the science or the disease or the medication efficacy there versus here? Well, the answer is there isn't. There isn't a difference. The difference is the value on which someone in the public healthcare system has placed on that particular medication. And this shouldn't be difficult because we have the common drug review. There are recommendations made, and there is a way to place these things from an evidence perspective on formularies that is mostly fair. It's not always fair, but mostly fair. And the provinces should uptake them and place them on their formularies, and sometimes they don't. Or, Kelly, even worse, they delay. The longer they delay, The longer the chances you start to flare, you can't make a decision because it's not available. You wait to make a decision because you think it's coming on board. Your formula, like it just creates a bit of chaos for the actual person who needs that therapy.
This year, as in past years, we saw some significant changes in the report card. For example, provinces added new biologics and biosimilars. We saw, for instance, Prince Edward Island jump 5 spots, while Alberta dropped 3 spots in the rankings. What's driving those kinds of positive or negative changes, and what is the impact for patients?
Well, obviously money, Kelly. So these are not inexpensive, even when it comes to a biosimilar. They're still not an inexpensive medicine compared to other medicines that are small molecule, been around a long, long time, but they're real life changers in terms of their therapeutic value. So often a province doesn't have the budget for it. They won't make room for the budget. So it's really, I hate to say this, a lot of times it's an accounting issue for provinces. But we know that in our disease state, by not covering these things, if it in fact is a discussion and a decision taken and informed by evidence, evidence that is supported by technology assessment groups like the Common Drug Review, who says list, if a province doesn't list, that right there, there's inequity. Um, so it means that the person, again, will use this interprovincial sort of comparison. Let's just use Ontario, for example, versus Nova Scotia. So someone in Ontario will have access to it. They'll be able to sit down with their physician, their rheumatologist in most cases, and say, okay, now this new medication is available. Let's say it's me. I've had disease for 36 years, Kelly, and I've been through everything. So those new medicines coming into our area, whether it's a new targeted small molecule or a new originator biologic, that could save my life, literally. Or if I've been someone who hasn't been able to get onto a biologic and a new biosimilar comes onto the market, then that means I have that as a choice, which is less expensive, right? They still have patient support programs. They're every bit the same quality and efficacy as the originator. And my drug plan can afford it, either public or private, actually. So it really is about trying to get the best therapy into the patient, obviously at the right price, at the right time, with the right decision-making support. So I hope I hope that kind of, it's a long-winded answer, but it gives people the chance to arrive at a decision with their healthcare provider, Kelly. And one thing that provinces need to remember, people who are elected officials or they're bureaucrats, they're working as a civil servant. No, a person like me can't be on two at a time. So bringing another one in offers an important opportunity to a new medication, and it doesn't increase the budget, right? I can't be on two at a time. It's either one or the other. And over time, these medicines lose their efficacy. We don't know why yet. Science doesn't tell us that yet. But over time, the efficacy of that medication is lost in me. I don't fail it, it fails me for some reason, biologically.
So you sort of touched on put some points on my final question, and
Yeah.
that is um, this year we find Ontario and Quebec, for example, are still again at the top of the report card. But there are provinces and territories like the Yukon, Newfoundland and Labrador, Northwest Territories where reimbursement coverage lags far behind. When we move from what we hope uh, our patient or consumer is able to, how they can benefit from this report card and use this report card, how does ACE leverage the report card when it is working and meeting with governments and public drug plans, and talking about how concerned we are through these report card findings that access to arthritis medication shouldn't depend on your postal code.
Yeah, well, I think the first thing we say is that the group of diseases these medicines treat, Kelly, are very serious and often life-threatening and often life-taking. That's something people, when they hear the word arthritis, and this includes a public drug plan person or an elected official, they don't understand that the word arthritis is that deep, is that broad, is that impactful. So that's the first thing we tell them. We are my cancer, my disease, I don't have a tumor. I have inflammation throughout my entire body. So inflammation is my tumor. And we're asking governments to treat my inflammation the way they've committed to treating tumors. Okay? It's that simple. Not pitting arthritis against cancer or diabetes or any other, but equity is the foundation. Okay? Understanding that untreated inflammatory forms of arthritis is crippling individually, but it's also crippling to the provincial economy, right?
Yeah, I mean,
It's
we always remind governments that arthritis is the leading cause of disability in
of work
Canada.
disability, that's absolutely right. It costs fortunes. So, and also costs hugely at the individual level. So that's kind of one of the first things we say to government when we're talking about high priced, but also high value medicines.
Hmm.
They just think of the cost. They have to think of the value delivered. Okay. That's in kind of the second thing. And then we also say that the spirit of healthcare in Canada has always been portability, right? And equity. And if someone leaves one province and goes to another, they very likely will find a different level of treatment available to them because of reimbursement policy, which is not fair. Okay. So I think those are three very important things we say to government to make them understand why this report card exists, why it's important for them to keep an eye on it. We also now, as you well know, moving into a new year shortly, we've been asking governments who have implemented biosimilars transition or switching policy that is delivering huge savings to their pharmacare area, to their ministries of health. And we are asking them to reinvest some of those savings, not just in our treatment area, in our medicine chest, so to speak, in others as well, but also in other aspects of our care that don't involve the medicine chest. We know that rehab services are hugely important. We know that reducing wait times of surgical for surgeries is essential and has worsened as the pandemic ended. We also know that delivering kind of community-based care is vitally important because we largely are 6 million plus Canadians who were working, right? 1 out of 4 people who have an arthritis, type of arthritis, there are over 100, are an adult who is working and paying taxes. And when we can't work because of our disability, then we're not contributing to society as a whole, and we're not contributing to our own happiness. We're not, I mean, people mostly love what they do for a living. They are performing work in the home. They're wanting to have a family. They're wanting to go on vacation. People are giving those things up, Kelly, just to pay for their medicines. And this whole notion of Canada having free health care isn't necessarily true for people living with arthritis. And I'm not even counting out-of-pocket costs for us. The arthritis community is one of the largest revenue producers in pharmacies that don't involve a prescription medication. So splints, braces, creams, you name it. Everybody wants to sell to people with arthritis because we're a huge marketplace. So We're really asking in a very sort of strong way, reinvest in us because our community has driven this huge savings from biosimilars back to the province.
And, for the provinces, territories, or federal drug plans that we think are doing a good job, we're also able to go into that meeting with a report card and tell them, hey, congratulations.
Exactly.
There's still work to be done, but it's a bit of a reward as well as a punishment sometimes for these drug plans.
Yeah, I think ACE has always been motivated by the carrot. And, we usually come at work very positively, um, but with a strong voice, and I think it's really important to show um, not just members across our community that we're strong, but strong together as rheumatologists with patient leadership, with membership, and then going forward to government and saying, look, this is what the evidence says. We're never going to argue for something, Kelly, that's not supported by solid research. Okay. I think that's super important for everyone who's watching to understand. And I think most do.
Well, it was a great summary, Cheryl. Thank you for walking us through the the early days and the origins of this report card to where it is today in 2025. As I said earlier, one of the more powerful advocacy references and tools that our community has and is used across the country. There will be a link to the 2025 report card at the end of this. We're always interested, as our audience knows, we listen carefully and always interested in what you have to say. So after you have a look at that report card, you see how your province or territory is doing. Give us some feedback, provide us some comments. We we take we take those observations and comments seriously, and sometimes take them all the way to the office of an elected official. So please give us your feedback. Anything that you have questions about, we're happy to answer them as well. And thank you for joining us, and see you again on the next episode of Arthritis at Home. Bye for now.